better indication of true cerebral functioning. So one of the things we need to bear in mind is that the most common method of assessment of fetal well-being during labor in the world in the 21st century is counting the number of times the baby's heart rate beats in a minute. That's it. The CTG is simply a recording of the baby's feedback. The CTG is a recording of the baby's heart rate during labor, nothing more, and a collection of maternal contractions and looking at the relationship between those two things. But I find it strange to think that with all our advances in technology, we spoke earlier on about MRI scanning, all of these advances we have, still the most common means of assessment of fetal well-being during labor is simply counting the baby's heart rate. You wouldn't, if I asked you to perform a physical examination to determine the well-being of a mother, you're not just going to check her pulse, are you? But that's effectively what we're doing with the fetus. In most cases during labor, that's all we are doing. So when we look at the evidence on fetal monitoring, I just want to talk very briefly about these three areas. But very quickly, I just want to touch base because some are in students, just very briefly about how to interpret forest plots. I know for many of you this is very easy and you're very experienced at it, but just bear with me for a couple of minutes. So this is the logo of the Cochrane collaboration. It's taken as a logo for it's taken as Cochrane's logo for a very particular reason, which I'll explain in a moment. So a forest plot is a graphical display of the results of individual studies which compare two things for a particular outcome. So if I give you an example, this is the Cochrane logo, but it is also a forest plot on the outcome of perinatal mortality. It's the forest plot that displays the findings when you compare the administration of antenatal corticosteroids to women who are threatened preterm birth, and when you compare that with not giving steroids, and you look at the outcome of perinatal mortality. So this forest plot displays the effects of giving steroids to women antenatally versus not giving steroids to women who are threatened preterm labor on the outcome of perinatal mortality. And very briefly, every single outcome in a meta-analysis, which is when you pool the findings together of individual studies, when you pool the findings of individual studies together for an outcome, every outcome will have its own forest plot. So if you have 10 outcomes, you have 10 forest plots. This forest plot is for perinatal mortality. Each horizontal line is an individual study. So how many individual studies do we have here? 7 individual studies, good. So the horizontal lines represents each individual study. The shorter the line, the more precise the estimate, the more confidence we have in that particular study's findings. It's usually a larger study with usually more events, usually more data contributing to the meta-analysis, the pooling. The longer the line, the less confidence we have, the more imprecise the estimates are. So interestingly, these horizontal lines actually are the 95% confidence interval. So the longer the confidence interval, the less precise the estimates. The narrower the confidence interval, the more precise the estimates are. The vertical line here is what we call, it's called different things by different people. The null line, the line of no effect, the 0 or 1 line. Basically, the vertical line is the point at which, if the study found no difference in the outcome between what was being compared, where the result would be. So, if the horizontal line touches or crosses the line of no effect, that means that study found no statistically significant difference in the outcome for those comparators. So in this forest plot, there are 7 studies. Each of those 7 studies compares the effects of antenatal corticosteroids with no antenatal corticosteroids for the outcome of perinatal mortality. How many of those studies found a statistically significant difference in the outcome? So many studies found a statistically significant difference in the outcome? 2. One here, one here. This actually touches here. Yeah. So 2 studies of the 7 found a statistically significant difference between the control and the experimental group for the outcome of perinatal mortality, because 2 of the studies don't touch or cross the line. If the studies are to the left of the line, it means a reduction. If they're to the right of the line, they mean an increase. So by looking at this simple logo, you can tell of the 7 studies, 2 studies found a statistically significant reduction in perinatal mortality associated with the administration of antenatal corticosteroids to women at risk of preterm birth. So if you're an obstetrician now and you have to take a decision, do you give this mother antenatal corticosteroids or not? Well, there are 5 studies saying no. It's no difference. 2 saying yes, administer it. All the studies are of different sizes, different countries, different dose regimes in some cases. And remember that the administration of steroids is not without consequences either. So it can also have a harm. Blood glucose levels, for example. Growth, perhaps. But you are right. But this evidence was available for up to 10 years almost before a Dublin woman, an Irish woman called Patricia Crowley, she pooled all this evidence together from these 7 studies, and she produced this diamond here. This diamond here is the meta-analysis. It's the results you get when you combine all of these together. If the diamond touches or crosses the line, it is not statistically significant. In this case, it does not touch the line, does it? It's to the left of the line. So the meta-analysis found a statistically significant reduction when you pool all the information together of perinatal mortality associated with the administration of antenatal corticosteroids. Not only did it find a reduction, it found a 50% reduction in perinatal mortality associated with administration of steroids. So this intervention clearly works. The reason Cochrane took this as its logo is this is an example of not where evidence was missing. The evidence was already there, but it hadn't been synthesized. It hadn't been brought together. When it was brought together, it demonstrated a clear benefit for a very simple intervention on a very severe outcome, a very serious outcome of perinatal mortality. And it's estimated that throughout the world, hundreds of thousands of babies died unnecessarily, not because of the absence of evidence, but because of the absence of synthesis of the evidence to give one answer. So if we take that information and we use those forest plots as we go through this presentation. So first I want to look at is the use of admission CTG. So the admission CTG is used in many countries. Is it used here? A tracing that's performed on the mother on her admission with signs of labor, usually a short tracing. And people say we do this tracing just to make sure the baby's okay, or to get a baseline assessment of how the fetus is. It's used in many, many countries routinely for all women. So we reviewed the evidence of what does the evidence say on its effectiveness, benefits and harms. So we found 4 trials reporting its use, combined containing over 13,000 women. And when we looked at the outcomes, women with an admission CTG, just the admission CTG we're talking about now, not continuous CTG during labor, women with admission CTG are more likely to have a cesarean section, about 20% more likely to have a cesarean section. They're more likely to have continuous electronic fetal monitoring and more likely to have fetal blood sampling. We found no evidence of a difference in operative vaginal delivery rates, your forceps and your von Too's birth rates, and no evidence of a difference in other outcomes. But the reason we do this is to check the baby's okay, isn't it? and to prevent harm, particularly death. So what impact does emission CTG have on perinatal mortality rates? Well, here's the forest plot. What does it say? You now know how to interpret the forest plot. In one of the 4 studies contribute data, 1 study had no deaths. It was a relatively small study. The other 3 studies each presented data on perinatal mortality. So none of the 3 studies found a reduction in perinatal mortality associated with emission CTG. And when you pool the evidence together, the diamond, the meta-analysis, is bang on the center, absolutely zero evidence demonstrating a beneficial effect for the emission CTG on perinatal mortality. Okay? So, surprisingly, we have no evidence of any known benefit for the emission CTG's use in modern maternity care. But yet it's used in many countries. And we have evidence of it increasing cesarean section rates. So here's probably a much larger meta-analysis. So this is when we compare the use of continuous CTG with intermittent auscultation. So putting a mother on a continuous CTG during labor and comparing that with intermittent auscultation, listening in with a handheld Pinard or the Doppler. And this is an important review because this review has been picked up by WHO, NICE, RCOG, lots of bodies have picked up, the RANSCOG have picked up this review. So what do we find? Well, with 13 trials, 2 of which were judged to be the highest quality, but quite a lot of women, 37,000 women combined. And we found that women with a continuous CTG, overall, across all the studies now, they're more likely to have a cesarean section for abnormal fetal heart rate pattern. And they're more likely to have an instrumental vaginal delivery. So they're 65% more likely to have a cesarean section and about 30% more likely to have an instrumental vaginal birth. We did find that the babies of women who had a continuous CTG were less likely to have neonatal seizures. Now, interestingly, we found this across a number of studies. For some reason, babies of mothers born who had a CTG performed were less likely to have seizures. When we looked at the studies who'd followed those infants up long-term, those seizures weren't associated with any long-term consequences, such as cerebral palsy or other neurodevelopmental delays. We don't know why this finding is there. We do know from the evidence that is available, and there isn't a lot of evidence, it's only a small number of studies that follow the infants up long-term, that those seizures are not associated with long-term consequences. Interestingly, we found no evidence of a difference in babies who were monitored continuously versus those intermittent auscultation in cerebral palsy rates, in perinatal mortality rates, in umbilical cord blood acidosis levels, or in use of any pharmacological analgesia. We then looked at the review and we looked at low-risk women versus high-risk women. So in many countries, we say low-risk women should be monitored during labor by intermittent auscultation, and the CTG should be reserved for women who have high risk factors. So we want to let's look at those women and see what happens with the CTG. So for low-risk women, we found pretty similar evidence. Higher cesarean section rates, higher instrumental vaginal birth rates, and more babies admitted to special care. It's in this group of women, the low-risk women, where we find a reduction in the seizures. And similarly, for the low-risk women, we find no difference in perinatal mortality rates. But here's the really interesting thing, I think. And this is a thing that's often ignored. This information has been picked up by lots of guideline groups internationally. But the same Cochrane systematic review, when we look at high-risk women, this is what it says. So now we're looking at only high-risk women. It says women with continuous CTG are more likely to have a cesarean section, less likely to achieve spontaneous vaginal delivery. We find more babies of women who are monitored by CTG have cerebral palsy, but we do know why that is. That's due to one small study which included very severely preterm infants of very low birth weight, and they had a 17% incidence of cerebral palsy. So we have suggested in our Cochrane review the finding of cerebral palsy here, that should be interpreted as cautionary, to the point that I wouldn't base a decision on that. It's one small study that's heavily influencing the findings. But interestingly, if you look at this closely, for high-risk women, use CTGs, not associated with a difference in perinatal mortality or neonatal seizures. But we do need more research to follow up what's the long-term consequences of the seizures we found in low-risk women. But at the moment, can you identify any benefit of continuous CTG from the Cochrane review for high-risk mothers? So we found no benefit of the CTG for high-risk mothers for any of the outcomes we looked at. And we looked at a lot of outcomes. So in that same Cochrane review, can I ask, do you use fetal blood sampling here? No? No, okay. Interesting, you don't. Most guidelines recommend you use fetal blood sampling in the presence of CTGs that are suspicious or abnormal, where delivery is being contemplated. But the fact you don't use it might be a good thing. So let me just explain. So in the very same Cochrane review, we looked at when you compared women who have CTG without recourse to fetal blood sampling with women who have CTGs with fetal blood sampling. And what we find is more instrumental deliveries associated with the use of fetal blood sampling, less neonatal acidosis, and a no difference in other outcomes. But one of the major reasons for doing fetal blood sampling on a suspicious fetal heart rate pattern is to allow more time to have a spontaneous vaginal or an instrumental vaginal birth, i.e., it's being advocated to reduce the likelihood of a need for a cesarean section. So remember that most guidelines that I'm aware of recommend the use of fetal blood sampling during labour as an adjunct to CTG. Yet in our review, this is what we found. And look at this Cochrane review here. Look at this forest plot. This is our findings for cesarean section rate for women, CTG with fetal blood sampling and CTG alone, no fetal blood sampling. We found no interaction effect, we call it. No significant differences between those two subgroups. So we don't have high quality evidence demonstrating a reduction in cesarean sections associated with fetal blood sampling from the perspective of the Cochrane review. So in the European literature, there's a big debate going on at the moment where you have NICE guidelines recommend the use of fetal blood sampling. And this is an article from the British Journal of Obstetrics and Gynecology in 2014. And Edwin Shalandran, who's in St. George's Hospital in London, he wrote, hence the NICE guideline group that recommended the use of fetal blood sampling in clinical practice without any scientific evidence, but based on the guideline group's individual clinical experience, should urgently review the recommendation in light of the evidence by the Cochrane systematic review and reported serious complications. In the meantime, obstetricians should critically review scientific evidence pertaining to fetal blood sampling before performing this test. So lots of individuals are now questioning the use of fetal blood sampling, none more so than people like Edwin Shalandran. The other one I want to talk about is the expert systems. So we know, and we've done this good work on this, if you give the And this is one of the problems with CTGs. They've got very large inter and intra-observer variability. So we know that if you give the same group of clinicians the same CTG tracing to interpret, you will get some differences of opinion in the room. Do you agree with that? If you give the same tracing to different people, if I give the same tracing to you all here and ask you to write out your interpretation, I bet we will get some differences in interpretation. Frighteningly, we also know that if you give the same CTG to the same person on 2 different time periods, they'll disagree with themselves sometimes. Because the CTG, the interpretation is rather subjective, isn't it? I noticed in your case presentation this morning, you used the term fetal distress, and we use the term fetal distress too. But one of the problems I have with the term fetal distress is the CTG machine doesn't print out fetal distress. It prints out the heart rate and the contractions, and you, the clinician, interpret that as fetal distress. But when you have an abnormal fetal heart rate pattern, will most babies who are born with an abnormal fetal heart rate pattern be acidotic or not? Most babies with an abnormal fetal heart rate pattern will not be acidotic. Most babies with an abnormal fetal heart rate pattern will have a normal APGAR score. Most babies with an abnormal fetal heart rate pattern will not require resuscitation. So who was distressed? Was it the clinician or was it the baby? So we tried I've tried to encourage the use of the term, if you do a cesarean section, it's not for fetal distress. It's actually for abnormal fetal heart rate pattern, perhaps. Yeah? Because the machine doesn't print out the distress. It prints out the contractions and the fetal heart rate, and you interpret it as such. And a woman called Karen Nelson, N-E-L-S-O-N, has done a lot of work on severely abnormal CTGs, so looking at late decelerations with reduced variability and looking at the predictive value of those severely abnormal tracings and the development of cerebral palsy. Most of those tracings, the infants will not end up with sufficient insult to develop cerebral palsy. Only about 2% will. That's for the severely abnormal tracings. So even with severely abnormal tracings, they're very poorly predictive of neonatal brain injury. And that's okay. Some people would argue, well, Declan, even if CTG captures 2 babies and prevents severe neonatal brain injury in 2 out of 100 infants, that's okay. I will take those consequences. The problem is, to prevent those 2, you have to cast a very wide net and intervene by cesarean section and other means on hundreds of babies. And those interventions aren't without their own consequences of morbidity and indeed mortality. So one way to try and help the situation is, let's take out the human being and let's get the machine to interpret the CTG, because it will do so more standardized, remove the human subjectivity, and let that help. So we've looked at that. What difference does that make? So at the time we did this review, we found 2 trials, and we found only one of the studies contributed data, and we found there was no strong evidence that using a CTG with the computerized interpretation or expert system reduces the need for cesarean section or instrumental vaginal birth or improves babies' outcomes. And we said larger randomized trials are needed, and that's exactly what happened. Now, some of you may have heard of this trial. It's one of the largest trials ever conducted in maternity care internationally. And this is it, the infant trial, published last year. And it's one of the largest individually randomized trials ever conducted in maternity care in the world, conducted by Peter Brocklehurst and his colleagues in London. He was in London at the time, he's now moved to Birmingham. And they randomized over 47,000 women randomized individually. 47,000 women. And they randomized half of those women to receive care in which there was an expert system, so computerized interpretation or alert system, compared with traditional CTG to see what difference in outcome it made. And this is the conclusion. We noted no difference in the incidence of poor neonatal outcome between the groups. And the conclusion, use of computerized interpretation of CTGs in women who have continuous electronic fetal monitoring does not improve the clinical outcomes of mothers of their babies. So such a large study, 47,000 babies, it is highly likely that that question is now answered. Computerized interpretation compared with traditional CTG doesn't improve the outcomes. Are you surprised by that finding? A little bit surprised. I think for me, one of the challenges I have is that if I showed you all a tracing, particularly senior people, if I showed you a tracing and I said, what would you do? You immediately, particularly senior people, are going to say to me, well, I can't answer that, Declan, unless you tell me what stage of labour she's in, her parity, her history. You won't answer unless I give you more information. And some of the key, the most important pieces of information you need to know, in my view, during labour, when you see CTG, are two things. What is the mother's parity? So has she had a vaginal birth before? Because that influences the time frame dramatically. And number two, what stage of labour is she in? Is she first stage 3-4 centimetres, or is she fully dilated? Because that changes your decisions. The computer can't tell that. The computer can't process the stage of labour, her parity, contractions. One of the criticisms that I have of any CTG categorization system that I'm aware of, or classification system, is most categorization systems that I'm aware of internationally do not include uterine contractions as part of the criteria in categorizing the trace. They include baseline fetal heart rate, baseline variability, accelerations and decelerations, but don't include contractions. But yet the CTG is fetal heart rate and contractions combined. We must have both. So that's a brief whistle-stop tour over some of the evidence underpinning some of the fetal monitoring methods we have of monitoring the fetal well-being. I think it's important for us to accept that, as I said earlier on, that the means we have of assessment of fetal well-being internationally during labour are relatively primitive. We effectively are counting a baby's heart rate. The reason we still rely on that technology is we have nothing better at the moment. Despite all the efforts going on, we don't have a better means of assessment of fetal well-being. So in 1821,